Gina, can we start? Good evening. I'm Dr. Jean Joseph. I have the distinct privilege of serving as chair of the Department of Urology, the Winfield W. Scott Professor and Chair at the University of Rochester Medical Center. And it's a fantastic opportunity to work with a group of fantastic physicians and advanced practice providers and admin team members to really advance every aspect of our mission, which really to build on our foundation to advance patient care, to educate the next generation, and to perform groundbreaking research. So we have a great admin team to support us, and I want to thank Jillian for help in orchestrating this event, which is, of course, Movember, and you all know what it's about. And it's very much in line with the work that many in the community have been doing, the work from our colleagues at OSTU, the Richardsons. Thanks for being here. And thank you all for joining, and in person and online. We are addressing a very important topic, men's health, health awareness in men. So there is a woman out there we're not aware how to best care for ourselves. And it's always good to see ladies in the audience. The fact is that men are affected by a number of conditions at a much higher rate than women. Again, prostate is a different conversation here, but in general, men die at a younger age than women for a variety of reasons. Higher risk taking, a number of areas where we would rather follow what women do as far as better caring for ourselves. And specifically in awareness, being more attuned with healthcare issues, be more proactive in caring for ourselves, and be more aware of issues, aware of our numbers, our blood pressure, our blood sugar, our PSA numbers. Overall, there is a need to have these conversations to help empower men to take better care of themselves, to engage in the conversations with their providers. So this evening, we're focusing on men's health awareness. Prostate cancer is a backdrop for it, but when we talk about multiple issues, we will first begin with an outstanding colleague with whom I've had the privilege of working for a number of years now, a great medical oncologist. He'll discuss the topic, management of advanced disease, advanced prostate cancer. Really where we don't want to be, but unfortunately sees a lot of these patients with advanced disease. Why? Because of the prevention, or more so the awareness, or not checking enough. So he'll be discussing advanced disease. And later on, my colleague, Dr. Fry, will come in to discuss diagnostic considerations on new technologies and how we are making strides in better diagnosing patients. And we'll conclude the evening discussing some of the also important issues when it comes to navigating the challenges, navigating the diagnosis. It's a lot to go through. From the diagnosis stage, it's not a pleasant test to go through. And the emotional toll of knowing you have cancer, what type of cancer it is it deadly, is it not, and go to treatment or not go to treatment. When you go to treatment, how do you go to the survivorship aspect when it comes to navigating potential side effects of erectile dysfunction or incontinence, things we hope not to see, but unfortunately has to do with the stage of the disease. If it's early, a lot of the complications can be avoided, but a lot of times they can't be avoided. So we have a spectrum. The discussion is quite broad this afternoon, and we're certain you'll find it of great value. And the speakers are here to interact with you, so do write your questions down, whether you're here in person or online. You can ask the questions to the chat if you're online, and we'll be sure to address them as best as we can. So once again, welcome to UR Medicine Urology and the Wilmot Cancer Center. That's it's a satellite we technically have here. And without further ado, I'd like to introduce my colleague, Dr. Chunkit Fong, who is a faculty member of the Wilmot Cancer Institute, an outstanding medical oncologist. Thank you for being here, Dr. Fong. I didn't go to my slides, did I?
Oh. Let's see how.
There we go.
Oh.
Well, just stay. So Dr. Fong is in the middle. You lead the conversations. These are the topics. And important to mention that at the Wilmot Cancer, stay right there. You're good. At the Wilmot Cancer Institute, it's a team approach. When I see a patient with prostate cancer, when I diagnose a patient, typically the internist refers a patient to us after suspecting a potential diagnosis, a primary care physician. So we do that diagnostic steps. When that is done, we are very quick to engage Dr. Fong or Dr. Byland, Dr. Cummings from radiation oncology. So it's a team approach. We do surgeries, the medical treatment, the radiation. There are multiple approaches, and the approach is really what is best for the patient. And just sharing some of the goals I mentioned earlier, as far as our goal to be a destination for patient-centered care. And we continue to do well from a training standpoint. And so I'll move on to get Dr. Fong to get started. Thank you again for being here.
Thank you so much, Dr. Joseph, for inviting us today and gather here. And it's so great to see so many people joining. And my talk is very interactive, so you can stop me anytime. And I just want to answer questions you may have for me or for others in the room. And it's supposed to be educational. So I'm a medical oncologist. That means that I care for prostate cancer using medicine, unlike the urologist who does surgery or radiation doctor who uses radiation. And usually when we see patients, they usually have more advanced form of prostate cancer. So today we're going to give a very general overview about advanced prostate cancer. So as you know, prostate cancer is the most common cancer in men, as you can see in this statistical slide. And that is the second most common cause of death, unfortunately, still for men, for cancer death. But I can tell you, since I finished my training more than 13 years ago now, there are a lot of new progress in prostate cancer. So we're very hopeful. And you can see that this is a slide from the US Cancer Statistics Working Group showing you that most of the prostate cancer, it affect people of older ages. As you can see, is likely around the range of 60 to 70s. So that's the slide showing you that. And here is a slide showing you, again, from the same US Cancer Statistic Working Group, how it affects different ethnicity and race differently. And you can see here, as we understand prostate cancer better, we understand the genetics of the disease can be different between different race and ethnicity groups. And family history does play a role, as you can see from later on in the slides, that it does. If you have a family history of prostate cancer, there's a higher risk that you are predisposed to developing prostate cancer. The graph here shows you the top line shows father and two brothers with family history of prostate cancer. And you can see that it's the highest probability. You know, the y-axis represents the probability. Those people who have a father and two brothers with prostate cancer have the highest probability of developing prostate cancer compared to the two brothers, father and one brother, or the general population, which is the bottom line. So it shows you family history does matter. So this is a slide, a very busy slide, but it gives you an overview about treatment of prostate cancer from localized disease to more advanced disease. I think it's useful to depict this in this pictorial form so you understand where the disease is at. So the top box depicts localized prostate cancer. Most people, when they develop prostate cancer, they usually find them early on, and they usually found them when they're still localized to the prostate area. For people who have localized prostate cancer, depending on the Gleason grade, or now we call grade group 1 to 5, the very low risk disease, sometimes they can do active surveillance. For people with more advanced disease, localized advanced disease, such as intermediate risk disease, high risk or very high risk disease, we sometimes talk about radical prostatectomy performed by urologists. Or radiation treatment. Radiation composed of external beam radiation, or C, what we call brachytherapy. And now there are more and more studies, looking at more precise treatment to the prostate lesion based on the MRI prostate findings, such as some ablative techniques. And actually, in the Department of Urology, Dr. Fry leads a localized prostate cancer program that looks at cryoablation, that looks at HIFU therapy for treatment right now, really focusing on recurrent prostate cancer after radiation treatment in the prostate gland. So that's something that the urology department is really innovative and really leading the way in this area by Dr. Fry and Dr. Joseph. So that's really the earliest stage of disease, localized prostate cancer, and that's the goal, is to cure people. Then the second stage, which is becoming less and less relevant because of our better testing, imaging testing, in picking up very small cancer cells, which I will touch upon a little bit, is called biochemical recurrence. What that means is that, for example, you had surgery to remove your prostate for localized prostate cancer, or you have radiation treatment to treat your prostate cancer, but then your PSA start going up. After surgery, your PSA should really never be above 0.2. After radiation, after your hormone therapy, if you get hormone therapy wears off, it should not really rise 2 points above the lowest level. So if that PSA start going up, but then when you do imaging studies, you don't see any prostate cancer cells, that's what we call biochemical recurrence, just the PSA going up, but radiographically, you don't see anything. Am I making sense? So that means that microscopic cancer cells are somewhere, but that on the imaging, the resolution is not good enough to pick up. Why I initially said it's becoming less relevant is because of a new imaging study called PSMA PET-CT that we do quite often now. There's a much more sensitive and specific test in detecting even smaller cancer cells, unlike the typical CAT scan and bone scan. So before, what we call biochemical recurrence, with a highly sensitive test, we actually pick up more cancer cells and we can treat it earlier. Does that make sense to everyone? So now we go to the next stage, what we call metastatic disease, okay, or metastatic disease. So you can look at metastatic castrate-sensitive prostate cancer, CSPC, castrate-sensitive prostate cancer. That is low volume, meaning that the extent of metastatic disease is not everywhere. Or you can have metastatic castrate-sensitive prostate cancer, high volume, they're everywhere. The goal of treatment in these instances are really more palliative. The goal is to treat the cancer so that you still have good quality of life and prolong your life, survival. And many people can live many years, even though dealing with metastatic prostate cancer. And we want to make sure that patients still have good quality of life while going through this journey. For low volume metastatic castrate-sensitive prostate cancer, the low volume, just with few metastatic sites, there's more and more evidence to suggest that it might be helpful to have localized treatment even to the prostate or oligometastatic disease, meaning that maybe 1 or 2 bone spots, you do as much as you can to give the most aggressive treatment with radiation, surgery, whatever that might be, in addition to systemic treatment. For high volume, there's really not as much evidence showing that very aggressive localized treatment to those metastatic sites would be helpful, but there are many studies looking into that question. So for metastatic disease, the standard treatment, the backbone is what we call androgen deprivation therapy. I think when you say hormone therapy, it's a misnomer because our goal is not to give you hormone, it's actually deprive you of hormone. Because testosterone is the hormone that makes the prostate cancer grows. So the backbone is ADT, what is androgen deprivation therapy, is a form of leuprolide injection. Leuprolide injection can be Lupron, can be Eligard. They all work the same. It's just different formulation. It can be many different forms. Then also for low volume disease, we now add another treatment, using an oral agent, another hormonal treatment that lowers the testosterone or block the testosterone from interacting with the prostate cancer cells, such as abiraterone, what we call Zytiga, apalutamide, enzalutamide, Xtandi. So we usually do two treatments together because clinical trials have shown that by combining these two treatments, people have survival benefit. They live longer for a year and have longer than what if you just get one treatment. For high volume disease, actually, we can also add these hormonal agents or hormonal agents. Also, we would consider using chemo also. There's a study showing that if you add chemo to hormonal agents, actually people live even longer. So that's something that we talk to our patients when they're diagnosed with metastatic disease. Any questions about that? That's called castrate sensitive. That means that the cancer is still responding to lowering the testosterone level, okay? So the next stage is what we call castrate-resistant prostate cancer. Meaning that even though you're getting your leuprolide injections, such as Lupron and Eligard, your PSA start rising. So it's not working anymore. So it's called castration resistant. Your testosterone level is castrated, but now it's resistant to that. So there's an entity called non-metastatic. You can have just the PSA rising, but you still don't see any metastatic disease. Again, that you can use other hormonal agents to suppress that and suppress the cancer. But then it brings you to the big category of what we call metastatic castrate-resistant prostate cancer. As you can see, I usually categorize them into hormonal oral agents such as abiraterone, Zytiga, Xtandi, enzalutamide, or chemo, docetaxel. Docetaxel is something that we give as the first-line chemotherapy. Cabazitaxel, we consider if patients fail docetaxel, the first-line chemotherapy. There's also a medicine called Pluvicto and radium. So radium is a radioactive agent that travels to the bone and attaches to the bone. And then Pluvicto is the newest treatment. That's also a radioactive agent. They actually have something called PSMA, prostate-specific membrane antigen, is attached to it. So this antibody is attached to the radioactive isotope, can go and find the cancer cell that expresses that protein called PSMA. I call that more like liquid radiation in layman's term because it is infused through your body. There's also immunotherapy called Provenge. We don't use it that much. That's really for people who has really low volume disease, whose PSA is going up slowly. You use it much earlier on, usually before you use chemotherapy. Then finally, there are, what we call PARP inhibitor, the rucaparib, the olaparib, that we're going to touch upon in the later slide about the genetics. Based on the genetics of your tumor, there may be role for these PARP inhibitors. And lastly, pembrolizumab is another agent that I have used for people who have genes that show high mutational burden, which means that they might be, the tumor can work with the pembrolizumab. Pembrolizumab can address the tumor if they can work with those tumors who have very high mutational burden. So this is a very big overview of the cancer. Hopefully that is helpful to folks to think about where the stage of prostate cancer is. So I'm going to talk about genetics testing. So when we talk about genetics testing, there are two types. One is called germline. Germline means that is what you pass on to your offspring or what you inherit from your parents. Okay, so that's called germline. Then we're going to talk about what we call somatic. Somatic is what your tumor expresses. Okay, so one is germline that you can pass on, or you can inherit that from your parents. Somatic is what your tumor expresses, and they can be different than your germline mutation. Okay, so this is just a slide showing you the different DNA repair genes. As you know, cancer happens because the DNA starts replicating uncontrollably. So what happened is a lot of these genes that control repairing the DNA so that it doesn't go so the cells don't multiply, uncontrollably, is these genes help to repair DNA, so it doesn't do that. So now we know that these mutations in this DNA repair genes actually can be inherited by folks with prostate cancer. This is a New England Journal of Medicine article showing you that there are 16 genes in DNA repair genetic pathway, the slide I show. Around 11% of patients who have metastatic prostate cancer actually have these genes. The pie graph shows that the majority of these genes are BRCA2, BRCA1, CHEK2, and ATM. And what we know is that it's around 4.6% of folks who have localized prostate cancer may have these genes. But then for people with metastatic disease, it's much higher. As you can see, it's 11.8%. So this is something that we consider when you come to see one of us at the Cancer Institute or the Department of Urology. We discuss about germline testing. So this is based on the NCCN guidelines. So we definitely recommend germline testing for all people with metastatic disease, with regional no positive disease, any family history, very high risk or high risk localized disease. We can consider for those with intermediate risk disease with intraductal cruciform histology, or prostate cancer, or any other history of another cancer listed here, because that might be a cancer syndrome, okay? So that's germline genetic mutation. Then this is somatic DNA repair alterations. Make sure time is good. So around 10% of primary prostate tumor may have these alterations somatically, okay? And then around 25% of metastatic prostate cancer may have these DNA repair gene alterations. So the reason I mentioned this is that a lot of times when people have metastatic prostate cancer, we usually send the tumors out for what we call somatic genetic testing to test the tumors. Do they have any of these mutations? Right now, if we find these mutations, it really only affects the treatment for metastatic disease. Really advanced disease doesn't really affect the localized disease. So I don't want you to go out there and ask, your urologist or someone, can I have somatic testing? Because right now, usually it doesn't affect the treatment right now. So these are the two pills that have been approved in 2020, olaparib and rucaparib, based on the different mutations. BRCA mutation for rucaparib, and then for olaparib, homologous repair gene mutation for metastatic castrate-resistant prostate cancer. These are the PARP inhibitors, okay? And then lastly, I mentioned about the immune checkpoint inhibitor pembrolizumab as an infusion. For people whose tumor somatic mutation has what we call microsatellite high or high mutational burden, actually, we can use this agent for any tumor with these genetic markers. Has been shown to be very effective. It's very rare for prostate cancer. I treated maybe in the last few years, maybe 2 or 3 people with this, but it works pretty well when you have those mutations. So last thing I want to talk about is a protein called androgen receptor splice variant, or ARV7. This is just a diagram showing you this protein and what that really means. ARV7 is pretty much a marker to show that if you have this marker, your tumor may not work as well with the hormonal agents such as the Zytiga or Xtandi, the abiraterone and enzalutamide. So as you can see here, if this protein is truncated, and these letters and numbers just means that, if you have these mutations, you may be resistant to these different hormonal agents. So we know that if you have this protein, truncated protein, what we call ARV7 positivity, you might have lower PSA responses, poor response to second generation oral agents, androgen agents, or shorter progression-free or overall survival. So this is just a graph showing you here. So I want to go through this. If the dark orange line, which is the bottom line on the graph, show that if you have the ARV7 positive protein, you may not respond that well to the androgen receptor, the second generation androgen receptors such as abiraterone and enzalutamide. If you're negative, for the black line on the graph, the top one, you see you respond much better. But when you give chemo, despite the middle two lines, despite the fact you have ARV7 positive, negative, the middle two lines, they cross. It doesn't really matter. So it shows that you have this protein, you likely would not respond to the second generation androgen receptor as well. So usually this protein doesn't happen before treatment with these abiraterone and enzalutamide, but it can increase to 19 to 39% after treatment on either abiraterone or enzalutamide. So usually we don't do this test before treatment, but if you're considering using another hormonal agent after failing either abiraterone or enzalutamide, you may talk to your doctor and they may consider doing this before they put you on it, because pretty much we know that if ARV7 likely you won't respond that well and may go straight to chemotherapy. Am I making sense? Yeah. So this is just a graph showing you that now I have the initial diagram showing you the different stages. The orange red circle showing that there might be some role for germline genetic testing, somatic genetic testing, and possible may do some ARV7 testing. That's it. So this is a very brief overview of all the advances, all the treatment options for advanced prostate cancer. I want to make sure I leave 10 minutes at least to answer any questions you have, because I promise this to be interactive. Thank you. Yeah.
So, talk about genetics. Oh, when you talk about genetic testing, why are you doing more at the diagnostic stage when somebody is first diagnosed with prostate cancer to see how aggressive their cancer might be?
Yeah. So
do you employ the Decipher genetic test at the beginning?
Yeah, so I think that's something that we do use, Decipher a lot, especially to determine how aggressive the cancer is. What I talked about is more for advanced prostate cancer. So, but definitely, yes, I think the urologists and radiation oncologists use a lot of those testing based on the genes to decide how aggressive it may be. Yeah.
During any studies have they done, if they find that when you're first diagnosed, someone has an aggressive type of cancer, but it's localized still, and say they do a prostatectomy.
Yeah.
Does that impact any immediate treatment after prostatectomy? Or the question is, does the data show that if you have an aggressive type of cancer at diagnosis, have a prostatectomy, what's the probability of reoccurrence down the road?
Yeah, so I think in addition to just the genetic testing, I think the pathology also is important to inform what's the risk that this may come back. But usually when you do the Decipher testing, they show you, what's the chance that it may come back in 5 years, 10 years. But when I counsel a patient, I look at the genetics testing score, I look at the pathology, I look at where the PSA is, right? And also radiographically before the surgery, how aggressive it looks. Does it involve any adjacent organs? Are the margins positive? Are the lymph node positive? Does it invade the seminal vesicle? What's the Gleason score is? So I think all of them, we take that into consideration. And there are a lot of nomograms to predict what the risk is. Did I answer your question? Okay. Yeah. Yes.
Is that a blood test or a biopsy or?
Yeah, it's
what?
a blood test looking at circulating tumor cells. Yes. So it's a blood test we usually get from patients. And usually insurance covers for it and it comes back within a week. It's a send out test. Yeah.
Thank you.
Yeah. Yeah.
So if there is reoccurrence,
Yes.
so, and I'm at the low volume stage right
Yeah.
now, so. And so I'm working with Dr. Van. Unfortunately, he's leaving, but we're gonna do a PMSA PET
Yeah.
scan in December.
Mm-hmm.
My PSA is 0.34 at the moment,
Yeah.
but I won't go into all those details. But the question is related to circulating tumor cells.
Yeah.
So if I have this PMA PET scan.
Yeah.
Maybe they find a lesion someplace.
Yeah.
And they treat it.
Mm-hmm.
But does that still mean I have circulating tumor cells that some point down the road, it could land someplace else and start growing a lesion? So is there a cure for circulating tumor cells?
Yeah, so no, that's a very good question. So as I mentioned, all imaging studies have limitations. So even though the PSMA PET is so good at picking up even smallest cancer cells, it may miss some tumor cells that may be circulating around. That's what you're getting at. So, but what we know is that by treating that 1 or 2 lesions, metastatic lesions, we can buy people's time to start another systemic treatment and buy people's time before the cancer become resistant to other treatment. So I wish I can say we can cure with just the systemic treatment of the radiation. I don't think we can say that. I think what we can say is that it does prolong the time that you need another treatment potentially, and then it prolongs the time that your cancer may develop resistant to other treatment. But I think I'm looking back at 13 years ago in finished training, really we just have one chemo drug and then the leuprolide injection. That's all we have. But in the last 13 years, with all these new drugs everywhere. So that's really reassuring. So I would imagine the more time we can prolong, the more new treatment will come about, and our goal is to cure someone. But if I say we can cure people with that stage, I would not be truthful. Mm-hmm. Yeah.
I had a 25% reoccurrence after 5 years.
Mm-hmm.
So if 5 years have gone by and I'm still undetectable, what do you think I stand? Where do you think I stand?
I think this is great news to celebrate. That means that everything went well. So, you know, how I look at it is that the longer it goes without recurrence, the less likely it's going to come back. Yeah. Yeah. How do I do that? Mm-hmm. Yeah. Yeah. Sure. There we go. So what we do now, this one? Okay. Yeah, so this is what we call the DNA repair genes, as I mentioned. And we know that prostate cancer, the for metastatic disease, around 25% might have these mutations. So if you have any of these mutations, they're a class of medicine called PARP inhibitors that works quite well, especially if BRCA1 or BRCA2 mutations. And those mutations can be expressed by your tumor, or you may inherit that, germline mutation also. So how we do the testing is we prefer to use a biopsy sample of your prostate cancer for somatic testing. We usually send the sample out to what we call, we use Foundation One here, medicine here. We send the sample out to Foundation One. And then they will run the test to look for any mutations that we might have a drug for. Right now for prostate cancer, the drugs that we can potentially use are the two I mentioned, the class of medicine called PARP inhibitors or the immune checkpoint inhibitors called pembrolizumab. But in addition to those mutations they test for, they also test for any mutations that might have drugs that work for other cancer. And they also look for clinical trials based on the mutation throughout the whole nation. So they match those clinical trial to the mutation. So that's how we usually do those testing in the clinic. We send the sample, but if biopsy is not something we can do, we can also send blood sample with circulating tumor cells, but we prefer to send the biopsy sample. Did I answer the question? Yes. Yeah. Okay. Mm-hmm.
The cancer tests and scores that range between 0 and 100, I believe the test name starts with 0. Or, I don't know if you just answered that one, but that's the one we
So
have.
I don't know what test we refer. Is it the Decipher test or?
It's just asked to elaborate on the test that ranges from 0 to 100.
Oncotype or Decipher. So I think it's just, if we are talking about Oncotype or Decipher test, the range, it just shows you how aggressive the cancer is, what's the chance that it can recur. And they usually on the report, they give you a range, they classify how aggressive the cancer is. I don't have that memorized, so I cannot really say that, but usually report, they give you different categories and they give you how aggressive it is and also what the risk of recurrence is based on that category of score. Mm-hmm. And based on that, the team of physicians will decide what may be best for that particular case to do. Mm-hmm.
Thank you.
Yeah. Yeah.
So related back to genetics
Yes.
and your treatments.
Yeah.
So I'm in a, Ben's prostate support group. So we
Yeah.
talk about a lot of things. And a lot of things that I read, it seems like with these treatments, you give a treatment, somebody responds well,
Mm-hmm.
and then at some point they're not responding and the cancer seems to come back. Other things that I've read is cancer cells are very smart in learning how to get around these treatments.
Yes.
So rather than giving a treatment for a long time and then the cancer cells figure out how to get around it, do you know of studies or do you practice where you'll do a treatment for a short period of time, stop it for a while, start it again, so that the cancer cells don't learn how to get around the treatment?
I'm not aware of any studies looking into that question. So what our standard of care is usually we treat it for as long as it works. And yeah, but that's a good question. But no one not that I know of that people look into this. But all we know is that by a lot of newer clinical study that looks at what we call upfront treatment for hormone-sensitive disease, the more aggressive we are upfront and to give it as long as we can, people live a lot longer. But definitely it comes with side effects that we cannot ignore. Mm-hmm.
Dr. Fung,
Yeah.
if a person had their prostate removed, say 8 years ago,
Yes.
is there any benefit of having an oncotype or genomic testing 8 years later? Is there any?
And the PSA is still good?
It's still undetectable.
I don't think so at this point. I don't think it's going to affect what people would do at this time. I don't think so. I mean, I don't, yeah.
Okay. And if the PSA started to rise over time, would there be any benefit then to get genomic testing?
I think at that point, if the PSA start going up, you see new spots somewhere, it might be helpful to do genetic testing of that new tumor.
Of the tumor that was removed?
No, that's growing.
That's growing,
Yeah.
okay.
Mm-hmm.
So if the
because as the genetics change, right? Like 8 years ago, it might be different. Maybe they escaped some pathway. Now the genetics is different.
The That's under the assumption that you find a tumor.
Yes, yes.
Quickly, my situation was in my operations after 2013. 2017, my PSA started going up.
Yeah.
Dr. Tom, radiation oncologist, they still had my prostate from 4 years earlier. So she sent it off for Decipher test and then determined how aggressive mine was. So I don't know if they still have your prostate 8 years.
They
now,
keep
but they
them.
Certainly had it 4 years.
They keep them. Yeah.
They keep them.
And then how long would they keep the sample of?
I think I don't quote me on this. 10 years maybe, Dr. Joseph, around? Yeah.
So
Around
I've got
10
two,
years.
I've got 2 more years to make a decision, or this person has 2 years to make a
And I
decision.
think, if you want to get it tested, it's fine to get it tested. But if, to be honest, if you, based on what I talk about germline mutation, if you belong to one of those categories that's recommended, you might want to consider that because it has implication for your offspring.
Right.
Mhm.
Thank you.
Yeah. Thank you so much. Really enjoy interacting with all of you.
Any of you can take, if you need a bio break, we have facilities over here and also one in the back. Both sides of the conference room, we have bathrooms available for those of you who are here in person if you need. We do have refreshments in the back as well for those of you who may need some. Our next speaker, Dr. Tom Fry, is here. He's setting up. And as mentioned earlier, he'll be discussing diagnostic considerations. Dr. Fung alluded to him earlier as to the great work he's doing leading our focal therapy program. Many of you have heard about HIFU. You've heard about cryotherapy. HIFU is high intensity focused ultrasound. Basically, what are we talking about when we treat prostate cancer? We can remove the cancer or we can kill the cancer. Removal, of course, is surgery. The killing involves multiple different modalities, whether it is radiation, which can be given in different forms. We also talk about heat energy or cold energy. If you freeze something, if you put your finger in the freezer, it dies off. Same thing happens when you put liquid nitrogen or essentially freeze the tissue, the prostate tissue. Similarly, if you heat it up too much by raising the temperature with HIFU, for example, you kill the cancer. So is he ready to go? Or okay, lovely. I want to make sure I'm not taking over his time here. So we use different modalities, and you'll talk more about different cancers. We use different approaches, and different patients want different things. And it's not a one size fits all whatsoever. And we have choices. We have options rather. And a lot of it has to do with the significance of the cancer. And Dr. Fung alluded to that, but not every patient should have surgery or should have radiation or should have HIFU or what have you. So we have to tailor it to the patient's preference, objectives, and what we call shared decision making. We get you involved with the information and for you to make the decision as to what works, what you feel is best for you with the best counseling we can provide you. So Dr. Fry leads our focal therapy program and he's an outstanding physician, and some of you may be his patients in here. So he'll be stepping up shortly to share with you his knowledge on diagnostic considerations. You have a question?
Yeah, well, and thought of shared decision making. Do you refer men to men's prostate support groups? I see somebody's got 0. I've been in a men's prostate support group at Cancer Support Community at Gilda's Club since 2013. so that men can get perspectives from people who have gone through it? So do you actually refer men to these groups? Because we know men don't talk about it.
You're correct. Men don't talk about it, that's correct. And I know we all very quick at referring to our colleagues to discuss the different approaches. Like I prefer not to discuss radiation with my patients. I send them to Dr. Zhang or Byron or Cummings because they're the experts. Clearly, my views tend to be focused on what I know, which is surgery. So I'm always quick in referring. So referring to other patients, what I often say is, I do pontificate in the sense I share what I know, but I refer patients to talk to others who walk their shoes. That's very, very important. So that's why I earlier recognized our colleagues from us too. And we as a department, as a cancer center, work very closely with Camp Good Days. They have a program there, they run yearly with us. And we have multiple programs throughout the city, folks we work with. So it's very important to have you here and to have the Richardsons here and to really have a community to be part of. So the answer is yes, we refer to support groups. That's very, very important. In fact, I'm having conversation with a medical oncologist who's interested in survivorships for us to target the partners, supporting the partners. It's very important because there's some dynamics there. Obviously, spouses, partners are there for each other, but the partners themselves are often left on their own sometimes. So we're working on developing a support group with partners. Another question there before Dr. Fry takes over?
People or men that have chosen active surveillance for their first treatment for prostate cancer, what percentage last 5 years or 7 years? Is there any data on how long men last on active surveillance? Do any men go to the end of life with on active surveillance and die of something else?
Absolutely. That's the major rationale behind active surveillance. Are you helping that person?
Is there data on how many have gone 5 years, 10 years, 20 years?
You want to address that, but frankly, it depends on the cancer that the individual has. So for low-grade cancer, low-volume disease, people do really well and never get affected by the cancer whatsoever and die of something else, as you said. But we follow our patients so that if there's a progression of some sort, then we intervene. So with that, I'll transition to Dr. Fry, who will, as discussed, talk about intermediate, also diagnostic considerations was part of the conversation. I'm sure that'll be covered as well. Very good.
Yeah, to answer that question, I would say, based on some data, based on the PROTECT trial done out of the UK, I would usually quote guys at least 10 to 15 years out, about a 50% risk of maintaining on active surveillance versus needing active treatment. But some of it's muddied a little bit by, well, what was really the indication for treatment? Was it just patient anxiety, or was there true progression of disease? So, it's kind of, ask those questions, but about 50%. Let's see here. I don't have any screen to look at except this one. So like Dr. Joseph said, I've been with the university for 8 years now. Fellowship trained in urologic oncology. So I did 2 extra years of training at the National Cancer Institute. Developed a real interest in prostate cancer along with kidney cancer, but prostate cancer, prostate imaging, newer treatment modalities and whatnot, and trying to kind of bring those sort of things to the university here in Rochester. So, I kind of wanted to, I put a brief talk together. I think also for this, it was more of a, can we just have a good discussion, get the questions answered, kind of see where the conversation takes us. But start out with, I have nothing to disclose. Well, that's important, if I own the HIFU company, and that might persuade me to act differently. But I think this is nothing that any of us in the room don't understand or aren't aware of, but prostate cancer is clearly the leading cancer diagnosis of men in the United States, and the second most prevalent cause of death from cancer in the United States. But with one man in 9 being diagnosed with prostate cancer in their lifetime, I think the recurring theme that you'll see is that many, many more men have it or are diagnosed with it than will die from it, right? And how do we justify this discrepancy in prevalence versus of significant disease versus what we classify as insignificant disease? And that's really where we're at. When we started doing PSA testing years ago, was the mid to late 80s when the PSA test first became indicated. There's been a 40% reduction in prostate cancer related deaths. Most of the modeling, it's complicated because the treatments have improved a little bit, but most of the modeling would say that, PSA testing probably has at least 50% contribution to that. But when we started biopsying a lot more people, it came with that increased diagnosis of insignificant cancers that we never really needed to find, right? And then the unfortunate downstream effect of that is potential treatments. And if we think about it, historically, we've always had these very dichotomous treatments. Either we do everything, take the whole thing out, or we do nothing and just watch it, right? And that's where we'll get into where focal therapy is kind of bridge that gap where maybe we treat the main focus of cancer and leave the rest of the prostate alone. So, here's what happened. Here's the, I don't know if this will, there's no laser pointer on this. So the red's the big uptick over time. You can see that's in the early 90s. All of a sudden, the rate of prostate cancer went up. Well, there wasn't anything that happened miraculously there that all of a sudden these guys were developing more cancer there. It was already in the population. We were just finding it. But what we have to remember is that at least 70% of those were low grade, what we now would call insignificant cancers, right? So we're finding all these types of cancers, whether it was insignificant or significant. So the PSA test is a useful screening test, and there's good data to support that. Problem is that if you don't use it, if you use it indiscriminately and are biopsying men unnecessarily, you are going to find insignificant cancer. So where has this led us onto the pathway of active surveillance? 20, 30 years ago, when people talked about active surveillance in urology communities, those people were shunned out of the room. They were almost, forced out of practice. Whereas now it's become standard of care. There's well done large studies. The main ones, Johns Hopkins, University of California, San Francisco, and University of Toronto have large active surveillance cohorts. But where did this all stem from too? So if you look at men who had their prostate out for a pure Gleason 6 prostate cancer, and they looked at how many of these men had lymph node disease or metastasis. 0. 14,000 men at Sloan Kettering. They looked at men with Gleason 6 disease. How many of them spread? 0. Gleason 6 does not spread. And that's why active surveillance started to become more mainstream. And there's other well-done studies, similar things. And so why, with the surgical data showing that, with the active surveillance data showing that, this is why, endorsed by all our national guidelines, low-risk prostate cancer, meaning Gleason 6, clinicians should recommend active surveillance as the preferred pretty strong wording, preferred treatment. You know, there's no benefit, long-term survival, decreased metastasis, anything of treating a Gleason 6 cancer. And we have to be very upfront with our patients with that, because with any treatment comes side effects. Will men on active surveillance potentially go on to need treatment? Maybe. But, you know, it's a win in that time frame of quality of life. They maybe weren't experiencing urinary side effects, sexual side effects, and really only treat the cancer when it potentially really needs it, right? And so that's where the field of low risk prostate cancer is really at these days. So what if you take it up a step and you think about Gleason 7s? That's the next step up. Now we're talking intermediate risk cancers. Do all these need treatment? Well, this is where the PROTECT trial comes in, 15-year data out of the UK that they randomized men between treatment or surveillance. This was the study that shows us the top graph, prostate cancer specific survival. So whether you had treatment or had surveillance, you had no survival difference at 15 years out. That's how slow growing these prostate cancers are. What it did show in that bottom graph, you see there's a little bit of separation of those lines. The solid lines versus the dotted lines, there's a little gap. That gap is the difference, that if you treated, the guys who were treated had a slightly reduced risk of developing metastasis or spread of the cancer compared to if you watched it. So, you know, when I counsel patients, you know, I think about these sort of things, right? These are the sort of things we have to all keep into context. You know, what are really the goals of treating this person here in the office with me? Is it a true survival benefit? Probably not, unless they're super young, maybe. Is it a reduction in the development of metastasis? Sure. I think that is a more realistic treatment goal. Can we reduce the risk that this cancer can spread? And I think we have data to show that treatment can do that. So if we think that some of these cancers may benefit from treatment and help reduce the risk that it could spread, you know, how can we do so in a way that is maybe a little less morbid or has less side effects than the standard approaches we've had in the past? And like I said before, it's always been this all or nothing approach. But if we think about all the other solid organ malignancies that are out there, most of them have some sort of organ sparing or gland sparing, whatever you're talking about, approach, right? If you have colon cancer, you don't take out the whole colon, you take out that segment of colon. If someone has a kidney cancer, we take out the cancer and leave the kidney in. The bladder, same thing, you know, it goes on and on. It just so happened that the prostate was kind of an expendable organ down there. You don't really need it. But its location is what causes all the issues. And so what about an organ sparing approach of prostate cancer? And that's really called focal therapy. Focal therapy is the broad bucket term of let's try and treat the main focus of cancer, where the cancer is at, and leave the rest of the prostate alone. And of course, you know, just like, you know, talking about any of these other organ sparing things, you know, not everyone's a candidate for every type of treatment, right? There's different volumes and grades and prostate sizes. You know, a lot of factors can go into play with these treatments. So what are really the goals of focal therapy if we're talking about this sort of approach? I mean, hands down, it relies on the location and characterization. So characterization meaning, have we given it the best diagnosis from a Gleason standpoint, from a volume of where we think the cancer is, you know, along with the location. And the MRI has really revolutionized that. We want to eradicate clinical meaningful cancer to achieve a good cancer control. And then that's where I always say this is the balance. The balance of getting a good oncologic control, cancer control, but balancing it with the quality of life. Can we reduce the risk of those urinary, sexual, bowel side effects, but still have a good long-term cancer control? So patient selection for this, if we're thinking about this, you know, location doesn't matter as much with whole gland therapy. You know, when we're thinking about taking out a prostate surgically, yeah, it's nice to kind of know where it is. We might take a little wider margin here or there, but it doesn't matter so much. You're taking out the whole prostate. It doesn't matter if it's in the base, left, right, you know, we know it's there. Same thing with radiation. But the diagnostic approaches that really help with location are the multiparametric MRI and image guided biopsy. Template prostate mapping biopsy is the most absolute. I mean, I think it's pretty, you know, morbid to go through in the operating room to take every 5 millimeter kind of samples of the prostate. So if we can accurately and reliably identify all the clinically significant tumors, you know, that's key. Can the disease localization help guide our treatment, right? Not only can it help diagnose, can it also help guide the treatment we're doing? And then can it also help post-treatment in, can it assess, hey, is everything killed, or do we have to be concerned that there could be a, you know, recurrence of cancer there? You know, so kind of can help in all three facets of this kind of treatment pathway. You know, that's what the multiparametric MRI is, that darkened area in the lower left of this prostate. The DCE is the contrast enhancement. You know, this is what we see. Some aren't as obvious as this, but it allows us to identify these lesions that we never could before, right? This isn't anything new. But this is why, you know, the standard is MRI before biopsies. You just can't do biopsies without MRIs these days. It's just can it be done? Sure, but I'd say you're missing a big step. So who's an idea? Yeah.
If MRI isn't showing anything,
Yeah.
could you still have a bias?
That's a more complicated question. So, you know, that would all depend on what your PSA is, your age, maybe your prostate size. So there are instances where you still would have a biopsy even with a negative MRI. Yep. Oh, yeah. So, you know, with patient selection, who's really ideal for a more focal type approach? Unifocal, meaning the cancer is more in one area or maybe one side of the prostate. A clinically significant disease. So again, we don't really care as much about those grade group 1 Gleason 6s, but something that's kind of in the sweet spot, these grade group 2 and 3s, which are the 7s, Gleason 7s. Ideally, we can, again, see it. So we know exactly where to treat and where to watch and follow up. And then the absence of any high-risk features, shouldn't really have any suspicion for seminal vesicle invasion, for any spread outside the prostate capsule, obviously any lymph node involvements, those sort of things. We want to the best of our knowledge, based on the imaging and biopsies, be somewhat certain that it's contained to the prostate. So that's really what we do. Treat the significant cancer, leave the benign or insignificant cancers alone. And what are the advantages? You know, we have to think about things differently, because it's more of a, are we causing cancer control versus a complete cure? Because the reality is, the cure word in prostate cancer, if you have a prostate there, is very difficult, because if you looked hard enough in most aging men's prostates, you're going to find cancer, right? So it may not be an absolute cure in the strictest definition, but if we can knock back the main focus of cancer, stop it from spreading in that man's lifetime, then that's a win. That's the goal we should achieve. It can hopefully delay or avoid any whole gland treatments, and then less side effects. They have far less erectile dysfunction with these. Urinary incontinence with these treatments is essentially nil. you can retreat things. You don't, I always tell patients, you don't really burn any bridges by doing these. We cannot, you kind of reset the clock with any sort of new diagnosis. You can always receive definitive treatment, surgery, radiation, what have you. So I think the disadvantages, I think, the real long-term outcomes are unknown. I'd say the outcomes 10 plus years, we don't know. There's good data that compares it to these focal therapies to radical prostatectomies, and it shows 8 years out, there's no cancer control difference. So that's why I always say, certainly the short and more intermediate term cancer control is I think right on par with surgery and radiation, which with far fewer side effects. And then the common question always is, like I said, focal therapies, the idea, the kind of big bucket term, but there's all the sorts of different energy modalities. The two most common ones that I do are the HIFU and cryotherapy. We had the IRE study here. There's radiotherapy, photodynamic, laser, the TULSA that you probably have heard about, golden nanoparticle. And now we even have the national clinical trial, the water vapor 2 trial up and running that I've treated some patients on. So the list will probably keep expanding. It's more about, have you selected the appropriate patient, I think, than select, what sort of energy are you choosing, because they all have different treatment characteristics based on prostate size and cancer location, any other treatments to the prostate, et cetera. So this is not a one size fits all thing. I mean, I think the key is, what I've tried to do is, at least when I started out, when I had HIFU and cryo, they're very complementary to each other of having benefits that are a little bit different from each other, so that it really allows you to treat a much wider swath of men if you have multiple options instead of just one. So, that's all I have. I think that there's a lot of new interesting things coming out, but it's the field's ever expanding, and we're continuing to kind of, push the envelope on this over treatment versus under treatment paradigm that remains in prostate cancer. So be happy to have any discussion and, answer any questions for you guys.
One question that came up, during your talk, you cited the Gleason grade 7 study, showing not much impact in longevity. Did that study-
That's all Gleason scores, but yeah, 7s too.
Did that distinguish between 4+3 versus 3+4?
Yeah, so good question. So that the header of that slide was a bit misleading, because it well about 7s, but that PROTECT trial was all Gleason scores. There's no survival benefit in any Gleason score versus observation.
I do have a question. So the Gleason scores coming from biopsies, and then Gleason scores coming from tumors post-surgery, are there differences? Let's say it's a 6 or a 7 or an 8. Do you rely on one or the other? So for example, in my situation, it was an 8, and then the surgery Gleason score was a 9. So that discrepancy, could you speak on that?
Yeah, the biopsy is you're just sampling a sliver of tissue, right? So there can be sampling error, and sometimes you'll undergrade a cancer, like in your scenario where you think it's an 8, but there's maybe a little bit more aggressive pattern there, so they call it a 9. But the opposite of that happens actually a little bit more than you might think too, where you think it's an 8 and you take the prostate out and it's actually a 7. And it's all just based on the pathologist being able to examine the entire prostate to just give it its final diagnosis based on what they see. There can be. You know, I'd say 20% of the time, up or down. But in the far majority of scenarios, like your scenario you described, it doesn't really change anything clinically, whether it was an 8 or a 9. Treatment would still be recommended.
All the treatments you had listed on the previous slide,
Mm.
are those all available here in Rochester?
Mm.
Okay.
HIFU, cryotherapy, IRE, and water vapor are the ones that I can do here now.
Okay. And if for some reason you think a patient might benefit from one of those others, do you recommend go to where they do it or?
Yeah, but I don't think they would. I mean, there's nothing different that's out there than what we're offering here that I think would be a benefit to them.
Okay.
Yeah.
You talk more on what IRE is.
Yeah, it stands for irreversible electroporation, but you know, probes are put in the prostate where we think the cancer is, and it causes electrical pulses between the probes and causes cellular disruption and cell death that way. It's you know, all these have different treatment patterns. It's a bit more focal, meaning it has a pretty tight kind of margin, tight area that I can treat with that. So normally, if I were to offer or think it was appropriate in men, it would be because it was at a very apical tumor, meaning closer to the urethra penile away from the bladder, because we don't want to, that's where the urinary sphincter is. So we want a really tight kind of control of our energy in that area to not damage the sphincter. Yeah, all these are one time. Outpatient procedures, you go home the same day. I'm good? All right. Thanks, guys.
As mentioned earlier, it's a lot to go through being diagnosed with cancer. And to hear the C word, people feel the ceilings coming down crashing, and understanding the mental aspect of it, the mental health issues associated with men's health, prostate cancer. Our colleague will be discussing, taking us through that. And as mentioned, to the question I was asked earlier, the support group, and very important. So you'll speak to the mental challenges. Please join us.
Great. Hello, everyone. My pleasure. Thank you so much for inviting me to be here. I'm Daniel McFarland, and I'm the director of the psycho-oncology program here at Wilmot. And I am trained as a psychiatrist and an oncologist, medical oncologist. So some of these issues in terms of communication are kind of near and dear to my heart. Let's see, I just want to be able to advance the slides. Okay, here we go. Yeah, okay. So I think one of them, so I see patients with all different cancers, of course, and I certainly see a lot of men with prostate cancer as well. And a lot of what I'm going to discuss is fairly generalizable just to having cancer. And I think that's an important place from which to start. Of course, within 20 minutes, which is what I was told I have, this is a very broad overview, not really delving into any one topic too deeply, which is unfortunate because, of course, it'd be great to do that. I hope that you'll be able to kind of take away a few pearls. So I want to talk about just the experience from the patient perspective, and then also from the family perspective, which is equally important, of course. And so, this, as we sort of have been discussing the situation with active surveillance, it comes to mind because this happens in many cancers where someone may be told, hey, that's not such a bad cancer, right? And there's some cognitive dissonance there. I mean, cancer inherently is bad. To be told you have not the bad cancer is kind of a strange thing. I can think of, say, thyroid cancer, is another one that happens at a younger age. And there's many types where people are sort of given that information. And it's a struggle. It really is. But I think everyone with cancer, certainly one of the things I put up here, sort of this acculturation, a simulation as to what is this all about? And it's, as you know, a huge educational burden that you have to go through and sort of learn. And then also be the spokesperson to your family, which is also a challenge, right? And so but the point is that no matter what the cancer is, the cancer situation, any cancer diagnosis is a threat existentially and changes a person's life. There's just no question about that. The way that it happens is always, of course, variable, although there are some very common themes. Okay. The other reason I bring that point up is because just because this cancer, someone might say, hey, that's not such a bad cancer. Actually, we know that the outcomes in terms of mental health are just as bad, interestingly. And this happens particularly in like thyroid cancer. Unfortunately, it's actually less known in the prostate cancer situation. I'm here at Wilmot, obviously, and I was at Northwell Health and Memorial Sloan Kettering before this. And we have actually a data set looking at active surveillance with some colleagues there. And interestingly, what we found was that it's not a large cohort by any means, but most of the patients actually did go on to active surveillance. But a few, about only 20%, had active treatment. And we found that actually levels of depression really predicted going on to treatment. Interestingly, the thing that we're looking at now is that those folks who had higher levels of depression but chose active surveillance, how good is their follow-up? Because one of the things that gets lost in this whole idea of surveillance is the active part, right? No, you actually are doing something. You have to kind of follow up, right? And so I think that's a very interesting question. Anyway, these are some of the things that one feels immediately in terms of hearing cancer: shock, fear, anger, frustration, disappointment, stress. Worries about side effects, what will happen, the idea of changing one's identity, one's role in society and one's family, having mood swings, anxiety, feeling alone and isolated. I mean, there's just a plethora of emotion, right? That can come, and it's kind of what life's about, having emotion. Of course, this sort of cranks it into high gear. And so one of the things that we look at just in general is sort of what is a symptom and what is a sign. And so a symptom is all those things that I was kind of going over before about what are you actually experiencing and feeling. And signs are things that we see outwardly. And that might be stuff like relationship difficulties, irritability, behavior, personality changes, not fulfilling tasks and doing the things that you're supposed to be doing. What I mean by decreased executive function is like making decisions, deciding on, making plans, planning ahead, and then ability to, the things that really is quite predictive of depression is the ability, of course, to care for yourself, but also to just kind of get out and get around. And right, as I was saying, that as I see a lot of patients obviously coming to clinic, more and more, I think this is true, that the experience sort of is on two levels of the adaptation to cancer is psychological, like in terms of what does this mean? As I mentioned, it's always a significant change, and it can mean many things for many different people. Of course, there are patterns. And then there's symptoms. The symptoms can be sleep, insomnia, can be pain, of course, depression. And the symptoms are important because there's, of course, this bi-directional relationship between physical symptoms and mental health symptoms or neuropsychiatric symptoms. And so that is, the more, let's say you have depression, your pain's going to be worse. The more you have pain, the more your depression's going to be worse. So what we do is we try to treat those concomitantly to the best of our ability. But the thing is that, and for some people, depending on sort of where they are in their life, what are the things that they've fulfilled, are their goals met or not met, that's where the psychological stuff really comes into play. And so we think about, there was this guy, Eric Erickson, who came up with these developmental tasks. What's interesting is as we get older, the developmental tasks kind of slipped off, but this is, his ideas were fairly, they were at the time very new, but now, but the idea is that as you get into middle age, it's sort of like, you know, are you generative, or are you sort of stagnant, and you know, and then you sort of have looking back on your life. I don't think it's possible to look back on life without some form of regret, right? But is there mainly a generally good feeling or not? And what is that really about? And so these are the things that having any cancer, frankly, will kind of bring into relief, and people will sort of say, hey, I really need to figure it out. I don't think cancer has a good time to come on. It always seems to come on at not a good time. So yeah. But that's the way that I kind of mentally divide it, is like, hey, what is this person working on? Are they dealing with kind of meaning in their life and working things out, or are they dealing with symptoms? Yeah. Interestingly, you know, depression, depression is very important, because a lot of the outcomes that I was talking about with that bidirectional relationships in terms of symptoms, of course, quality of life, and even survival are predicted by depression, frankly. Anxiety is fairly ubiquitous throughout the whole, you know, people get anxiety. We're meant to have anxiety as a signal of, you know, hey, got to do something about this. But what really counts in terms of those bad outcomes that we don't like is depression. But the thing is about depression is that it's actually not that easy to diagnose, because for several reasons, and actually even doctors aren't so great at diagnosing it. And so sometimes people say, I just don't know. I mean, unless you've had, so like 1 in 4 adults will have had a clinically significant depression in their lifetimes. That's helpful if I'm talking with a patient and they say, well, you feel bad, but was it like this other time, right? But for those other 75% who maybe have never had a period like that, it can be very difficult to, because they don't really sort of understand. And that's where this I went to med school to learn big words, and this was one of them. Alexithymia means, you know, I just don't have words for this. I don't know I don't know what I feel. I don't know how I feel. Well, that's kind of where signs are important, right? Like, are you doing those tasks that you need to do? How are your relationships going? And are, you know, are people concerned? That kind of thing can be helpful. The two biggest, you know, believe it or not, so I'm saying something kind of contradictory, because two very predictive questions are, hey, just, are you depressed? Do you feel depressed? And the other question is, are you able to have pleasure in things that you normally enjoy? So when people are depressed, they tend to, everything seems bland. There are things that they normally like just aren't there. If I have a patient who comes in and says, I don't really like seeing my grandchildren, I'm worried. Okay, so you know, these are, but that's the point. If someone says, I love golf, and they no longer love golf, well, hey, that's a big deal. So, you know, those that's kind of the red flag. The other red flag are thought patterns that are quite different. Not planning for the future, feeling hopeless, not wanting to do things, be around people that you normally enjoy. And certainly the depressive symptoms tend to be worse in the morning. And that's important because fatigue is sort of a part of many cancer diagnoses, but fatigue, when it's from the physical stuff, tends to be worse in the afternoon. When it's from depression, it tends to be worse in the morning. So yeah, right, as I was saying, what is it really? You know, it's sort of something to talk about with your doctor. And yes, of course, there's scales and things like that, but it's always a clinical assessment that needs to be made. And the other confusing part of it is that actually there's sort of clinical depression, which is these criteria, does the person meet? And then there's just having depressive symptoms that might be kind of coming and going like that. Where again, I get more worried about folks is when they have symptoms that are persistent, they don't really wax and wane. They may experience thoughts as sort of intrusive, they can't get rid of them. You know, those are more of the worrisome things. It turns out though that depressive symptoms, even that waxing and waning, actually leads to some of those bad outcomes. Like when we look at the studies that show, you know, quality of life and even survival, that wasn't clinical depression. They were depressive symptoms by self-report. So both are obviously very important. And the good news is that we have effective treatments for these things, which I wish I had time to get into, but I won't today. And, you know, this is obviously a big complicated slide, but it highlights some very important things that, like I was mentioning, some of the prevalence of depression, say. This is looking at about 20,000 men with prostate cancer. And it shows really over a period of time where mental health symptoms kind of come about. And so the pattern is that it's generally earlier in, you know, closer to diagnosis, particularly for depression. And again, anxiety is kind of there sort of throughout. You know, but some of the things that you might, you know, alcohol related disorders, actually not really different from the general population. And delirium, dementia, not different from the general population. So it's really the mood disorders that we kind of worry about the most, frankly. Of course, for any given patient, any one of these things could be a real issue. So, you know, some of the other psychological issues that come up is, how do I talk about the diagnosis with friends and family? And I think that can often get overlooked as something to kind of really go through. And, you know, I kind of have a thing that I'll say to patients about how they become the spokesperson of their disease. And I think that often sort of helps because that's been their experience, is like, hey, I'm already doing that. It can be very tricky with disclosing to work, can be disclosing with dating. But it turns out that our relationships are incredibly important. And so managing those relationships is really what this is about in terms of disclosure. And so it's fair to really spend some time to think about that, talk about it, and get help with it. Yeah, there's this notion of tyranny of positivity. It's probably every week or so that I meet someone who says, I just am told I'm supposed to be positive all the time. Yeah, and you know, that's tough, especially because, as we were saying, the experience is one of uncertainty. Even if you have that treatment, you still have the uncertainty. And so everyone who has any cancer is dealing with some uncertainty. Sometimes, you know, and that's kind of where this active treatment stuff comes in. It's like, we're going to make this certain, we're going to get rid of it, but there's still the uncertainty that's there. And that's harder when you have depression. So that's why the findings I was telling you about are not surprising at all. But there are other entities such as fear of cancer progression and recurrence, specifically about that. Oftentimes folks will have higher levels of anxiety. They might have been someone that had some sort of baseline anxiety at the beginning, then they get diagnosed with cancer. Now they're worried about everything. That certainly happens. But it also happens that now they're not worried about everything, just really worried about the PSA or the scan. And this is also important for medication adherence and follow-up. So, yeah, well, I think I probably won't spend too much time on this idea of the phases, because I think we probably all know acutely being diagnosed is really a trauma, if you will. The chronic phase, I think, is the most sort of relevant, and what it really means. It means that kind of re-equilibrating your lifestyle. There can be good that comes from it, and that's this idea of post-traumatic growth. It can help people to kind of see things in a different way, reevaluate their priorities and values. This can also be the case for the family, and I'm going to get into that in a second. Right, and so yeah, practical realities may have to change. We talked a little bit about is an underrepresented area that we need to do better on. The idea of resolution might be that, you know, things might come back to some sense of normality, or they may not. This idea of survivorship is also interesting, as it sort of goes throughout the cancer trajectory, but really is about adapting to a new way of being, because once you are diagnosed, you know, you have to sort of integrate that experience and make it your own in terms of what it means. Yeah. So the idea is that with family, of course, there's this reciprocal aspect. And, you know, I think that how we diagnose how we define family, you know, is somewhat variable. But again, if you think about it, family is always going through transition of some sort. And so there's always an effort to kind of maintain the stability, kind of reorganize. And the families that do this best are those that allow for flexibility. Yeah, and so talk about that in a minute. Another aspect of that family functioning is interfacing with the medical community, you know. And so sometimes we see families that you know, don't do that well, or they do it well. And it just depends. It's a little bit of a mix. We try to be open to the way that families are. But it's important to kind of go through a period of figuring out how you're going to do that. Yeah. And so again, it's just this sort of disorder of change, risk, loss, recovery. And, you know, with risk, there could be risk from treatment, could be risk from cancer. And a lot of what people experience, I mean, I would say that as we talk about cancer, one of the things that's important to at least in terms of mental health, really take in is that it is a loss, you know, that there is a loss that, you know, there may be, you know, life with cancer, life without cancer. If that transitional point, you know, there's a change. And so it doesn't necessarily mean that change is on the negative side, but, you know, you can't really take the cancer back. So in that way, understanding, and, you know, as I was saying before about, are the symptoms kind of stuck and pervasive, or do they come and go? The thing with the symptoms coming and going, waves, that's grief. That's what happens when you grieve, right? And so we have to grieve. Grieving is healthy. Grieving is something we're supposed to do. It's the same with this diagnosis or any cancer diagnosis. You have to be able to get beyond. And it's interesting because I actually see a lot of patients at about a year after they've been diagnosed with the cancer. What that says to me is that, hey, they got through their terrible treatment. Now they're on the other side and they're going, what just happened? And they're grieving. They're grieving and they need to. And so, yeah, I see many patients who are exactly right at that time point. So anyway, it's just important to let ourselves do that. Yeah. And so the main thing that I want to say about families, let me go to this. I want to have a little bit of time for discussion, so that's why I'm kind of going through this. But if you think about the structure of a family, like every family has, you know, where are you? You know, have you raised your kids? Are you going to have kids? Are you done with your kids? Are your kids out of the home? That kind of thing. And what's you know, families have illnesses in them, obviously. You know, is your family someone who's a family that's dealt with illness? And what are the different relationships within the family? Of course, for some families, siblings are very close, for others, they're not. And then there may be an experience with healthcare, right? If someone went through a terrible experience with a hospital, you know, that's going to influence how they're going to interface. Yeah, and a family's, of course, always changing. How does the family deal with stressors? These are things to kind of think about. And I think this is an interesting phenomenon of thinking about the family structure as, you know, this centripetal stages and centrifugal stages. So, you know, I'm not a physicist, right? But these are like some principles that I guess for medical school we had to learn about. You know, if you're like spinning in a circle, there's a force that goes inward and a force that goes outward. And the centripetal stages sort of bring the family together. That's marriage, first child, family with young children, grandchildren, retirement and older age coming together, and even death and dying. But those centrifugal stages are also important. Child goes away, child enters school, into adolescence, leaving home. Yeah, and again, that's just sort of where is the family. Move through that, yeah. Oh yeah, and of course with family history, you can't just restart the computer, get a new one. It's sort of stuck with it. Yeah, like I said, the optimal way is to have a range and flexibility in terms of your role with the family. And that's where people can kind of run into problems, is can be kind of stuck in one role. And, you know, families change as we get older. Yeah. what time do we have? Are we good? Okay, good. Yeah. Right. Yeah. And so, it's interesting because like people go home from the hospital or from the clinic, and then they're of course with their family, and that's the immediate context. And so family members can generally be kind of feeling like they're caught in this circumstance of the cancer. Of course, the patient's caught too. What I see often is that this is why, like I always sort of put it as a unfair kind of irony, I guess, that generally the patient's a little bit further on in terms of what does this cancer mean, and then you're sort of the spokesperson for the rest of your family. It can go the other way as well, but often just knowing that that's kind of the way it is helpful for people, because they know what they have to do. The biggest part of the battle is not knowing what you have to do. I think you could probably relate to that. So I'll find myself saying, you're right, this is exactly how you have to handle it. And that's important. The other part that's important is letting people know that they have control over how they talk about it and with whom they talk about it. And that's part of that disclosure part. And yeah, because sometimes people feel like they ought to do this, they ought to do that. Well, let's think about that. Do you really need to do it that way? Because at the end of the day, you want to, again, it's important, your quality of life and your relationships. And so, yeah, we sort of look for those periods of time where we can sort of intervene. And we know that there are points in time that are more stressful for patients and family, like recurrence, like if the PSA goes up, or if there's other issues. Hospitalizations are often pivotal points in the cancer trajectory. And when I showed that slide with all of the forest plot with all the lines, that, what I was really kind of one of the other points I wanted to make there was that timing is really key. So I said early on, that's what the symptoms really are. I could go on and on about all of those symptoms, but I won't. It's just timing. And so that's what we really try to do is sort of nip it in the bud if we can. Yeah, so we try to join with the family. Generally, when I'm seeing patients in clinic, we'll bring in the family or I'll talk to the family. That's really important. And yeah, we kind of go from there. These are some of the issues that also I was kind of getting into. Like I said, there's a lot that we could go into, but we don't have that much time. I talked a little bit about caregivers, and the caregivers are very much a vulnerable population. Only about a third are ever really assessed by a medical team in terms of their readiness to be a caregiver, which if you think about it, it's kind of mind-boggling, right? Like here's this person who actually is the most important person that you're going to deal with during the cancer journey. So in one of another talk I gave, I looked through the guidelines to see how many times family was mentioned. It's very few, and you think about it, that's sort of interesting because everything is patient-centric without necessarily being family-centric. And so that may or may not be an issue for people, but like I said, relationships tend to be the thing that people will kind of come down on in terms of this is what's really important. So that's kind of striking to me. Yeah. Anyway, for caregivers, the problem is that often they need to have their own help, and they're not able to do that because of time or financial constraints or other constraints. And so it is a real issue. Yeah. And anyway, I'll leave it there. Yeah. This website is very good, cancer.net. And so a lot of any questions that might come up for you, certainly you could access this online. It's for patients. Yeah, I've been involved in some of the writing there, which is quite good. And I will highlight one book that I think is a very nice read if you haven't picked it up. But Andy Roth was a psychiatrist. He is a psychiatrist, but he recently retired from MSK. And, he brings up some really nice topics, like he calls it emotional judo, just sort of talking about how we handle these feelings. And he's worked with men with prostate cancer really his whole career. So he knows a thing or two about this topic. So anyway, one resource that I highly recommend. Happy to take any questions, and thank you again for letting me speak.
So with prostate cancer and depending on your treatment, so especially if we to get prostatectomy, you know, your prostate's removed. So how do you, so one quote, how do you get patients? How are they referred to you? Is a urologist noticing that the person is, you know, is possibly depressed? And then I have a second question.
Yeah. Well, there's a lot of, they talk about screening, and so that's supposed to be done in clinic, and it is. And so there are screening forms, and so if, you kind of hit a certain mark, then the nurse or the doctor will, talk about it, hopefully. The other way is just, you have a relationship with your clinician. So people are reluctant to bring up their feelings with oncologists. And I get it, because you want them to focus on the cancer, and you might think, I don't want to overburden them, or, I don't know what, I'm probably, people have many thoughts, I'm sure, about why. I could tell you that because as an oncologist, I see patients as an oncologist too. So I know that happens. So yeah, I mean, to come to me or to go to any other service, it could be either from the clinicians can refer, or the social work is actually, we have a tremendous social work department at Wilmot, and so they're involved. And actually, that's how we get our patients, is primarily through social work, support groups, but even individually, all of our patients are at Wilmot because we're at Wilmot. But I heard someone mention Gilda's and cancer support community, and so there should be more. Unfortunately, there aren't more. I wish there were, but yeah, it's yeah.
And then obviously then when you've had a prostatectomy,
Yeah,
men are dealing with erectile
Yeah.
dysfunction and incontinence. I mean, it's a range. Everything's fine to, so do you deal with those? Because in our support group, if newly diagnosed men, before they have treatment, we're very, very helpful in just what questions they ask. But after they've had treatment and they come back and they start talking about these functions. So how do you deal with men that are really dealing with incontinence and they're, it's really affecting their relationships?
Yeah, no, that's a great question. I mean, of course, there's the practical side of what do you do, and what I deal with more is the emotional side. And so, and they can intervene, certainly in terms of well, both incontinence and sexual function. I mean, I could go through, like, there's different ways of talking about intimacy for sexual function, exploring those different ways that just kind of I could give you briefly what's called sensate focus. So it's just basically kind of using other sensation, to kind of have intimacy. And I think what it really comes down to, though, is what are the ways in which these changes are affecting your sense of self. And a lot of it is, obviously what can be changed, they're going to try to change it, or, sort of work on that. Where I come in is more with, well, things can't be changed, when things are sort of such that, there's a real need to accept what it is, whatever it is, right? And some of these obviously are evolving, right? So the incontinence or impotence can be something that might be there for a while, might get better, might not get better. And again, that comes down to this uncertainty issue, and so, there's not unfortunately a magic pill to kind of take that away. It's about, sort of how do you deal with it? But that's why I was sort of making this dichotomy of symptoms, right? Like, if you're not sleeping well, if you're super fatigued, it's going to make accepting these issues harder. And so there's a real kind of relationship there. But yeah, I mean, sometimes it can be a matter of focusing even on other things, other symptoms, And what I would say with someone who was really struggling with some of these issues is what is it about for them? What does it mean? Some interestingly, education. So I was recently kind of putting together a review for ESMO about anxiety and depression and insomnia. And it's amazing that education is one of the main modalities of treatment. And what that says to me is just how important it is to really, understand. I mean, again, like, what is the feeling? Like I mentioned alexithymia, not being able to identify it. Understanding what some of the choices are, going through some of the conversations that happen with other oncologists and surgeons and things like that. Sometimes there's a misunderstanding. Yeah, so you really kind of have to tease apart some of these things. In some, and there's just not a blanket way. Like for some men, one particular issue is going to be more important than another. So, we can't make those assumptions, right? That this is necessarily an important thing, but we always need to ask. So. Any other questions? Yeah, sir.
Dr. McFarland, thank you for that wonderful presentation. I really appreciate that. You mentioned effective treatments for depression, and I know you couldn't go into them in depth. Could you give me 3 or 4 of your top one-liners?
Yeah. Well, like I just said, look, so really what we do is medications and therapy, those are the things. And there are, so medications. So the deal with medications is this, that the SSRIs or antidepressant medications, they work generally. The problem is they're often not titrated to the right dose. And there's obviously ways of changing at the right time, maybe adding something. The point is you can get a lot of mileage with the medications. And now folks will often say, I don't want to take more medications, but again, to my point about managing these things and what's the real benefit, and there can be a real benefit with them. And I didn't say it before, but what I was sort of implying by talking about symptoms and the psychological was really symptoms are managed with medication, and the psychological is more of a therapy stuff. And that could be, therapy most of the time when you go see a therapist is what they call eclectic, meaning it has various styles of therapy, and it kind of should match where the person is. So it could be, the most commonly talked about is called cognitive behavioral therapy. And what that addresses is, what are the things you're sort of telling yourself in the back of your mind, and then is that relating to kind of your self-image and those kind of pulling those things apart. Another form is interpersonal therapy, which really actually looks at the relationships. A lot of the therapies that we do, these aren't therapies talking about childhood and what we call psychodynamic, psychoanalytic. They're present oriented. What are you dealing with right now? I heard someone talk about groups, and I love groups because I think you're able to kind of see like, hey, how is this person interacting with other people? And like I said, oftentimes, what gets talked about in therapy, I'll let you in on a little secret, is relationships primarily. And those are the things that really, that's at the end of the day, that's what's kind of most important to us. But it can be one's place in life. Like, hey, did I do what I wanted to do in terms of my profession, my occupation? Did I fulfill some goal that's more on a personal level? Sure, that can also come up. There are a lot of different there's something called TMS. There's all kinds of different things, but yeah, meds and therapy are primarily it. I should say exercise too, because that's really good. Yeah. No, but I had a gentleman who was on the older side and on ADT, androgen deprivation therapy, and he was just like, he was saying to me, like, I just my energy is just so low. And I think he really kind of forgot that he was on, testosterone blocking agents. And so it's like, well, maybe because he I think was about 88. He is 88. And, well, certainly he's getting up there in years, but he just started this medication, so it's sort of like understanding that, yeah, but the androgen blockers are really going to zap your energy, because he was interpreting that as, oh my gosh, like I'm really in a bad place or I'm dying or something. I said, no, I mean, you're otherwise healthy. You're just really tired from that. So that kind of, like I said, as human beings, we are highly adaptable, frankly. And so a lot of times, you know, you guys, everyone's really been through stuff and you have coping skills. What I see is that often changing a little bit of education can really help. And that's what's kind of nice about working with you guys. It's like, is, you know, 'cause people get better, right? And so it's nice. Any other questions? No. Thank you. All right. Have a good night.
Thank you, Doctor. That was awesome, and it's really providing a well-balanced aspect to the discussion because really it's a disease and people suffer in multiple dimensions, and addressing the mental aspect of it really very helpful. So thank you for that wonderful presentation. One more time. I also want to thank Dr. Fong, who did the first presentation, and Dr. Fry, wonderful colleagues who took the time to come here and share their expertise with you. I think Dr. Fry is still here if you have a question for him. But of course, I want to thank you all for being here, and those of you who are online taking part in this outstanding educational event. My thanks to the organizing team, Jillian and Ms. Campolito, who are back there. And of course, the AV team for being here, and our translator to assist us in communicating with our community. This is very important for us to do as a medical center. Once again, thanks for being here. And in the spirit of November, we're going to trim all those mustaches, those of you who have them, and have a wonderful dinner. And thanks again for being here and for sharing your early evening with us. Thank you.